Okay. So many of you may be looking around the virtual room for Bill Keck, our chair. And unfortunately, Bill is unable to be with us today. He's fine, he's healthy, he's on travel. And Bill asked me to step in to take his place for this meeting. Big shoes to fill. For those of you who may not know, I'm Ron Bialik, President and CEO of Public Health Foundation, and also Director of the Council on Linkages. And it's a delight to see all of you here today. We thank the Centers for Disease Control and Prevention, Center for State, Tribal, Local, and Territorial Support for providing the funding support that enables us to engage in these current and future Council on Linkages activities. So CDC, thank you so much. A few housekeeping items. I think at this point, we're probably all familiar with Zoom and housekeeping, but just a few comments. One is audio can be accessed by computer or phone. When you're not speaking, please leave your phone on mute or your mic on mute. We encourage everybody to be on video if you're comfortable with doing that. Comments and questions, you can be putting those in the chat box at any point throughout. And of course, when you are looking to ask a question or make a comment, you can unmute yourself and we can hear you. Excuse me. And if there are any technical issues, you can send a chat note to Samantha Draper. I think it's listed as, she's listed as PHF webinar. Right, so in case there are any technical issues. So as we get ourselves started, oh, I forgot to mention, yes, we are recording this meeting as well. To ground us, it's always important to look at the mission of the Council on Linkages. I'd like to turn your attention specifically to the third sub-bullet, developing and advancing innovative strategies to build and strengthen public health infrastructure. If you think about it, the past several meetings that we've had of the Council on Linkages really have focused on this because there are enormous opportunities today for rebuilding public health infrastructure and the workforce. And for us to be coming together to address that is so very important. The Council is comprised of 24 national public health and population health organizations. So thank you all for your involvement here. And it's critical for this group of organizations to be coming together to discuss these critical issues about public health infrastructure and workforce, to work on developing strategies for taking actions and for sharing information with the broader public health and population health communities. I'd like to take a moment and just review the agenda for today's meeting. We have a very packed agenda. Seems like we've been doing that for the past, I don't know how many meetings lately, Kathleen, on this. Of course, we'll have approval of minutes that will get us started. We're going to have a substantial session on rebuilding the public health workforce to continue the discussions we've been having. We'll have an update on academic health departments and core competencies. And then we'll also be hearing about two other competency initiatives, one about interprofessional collaborative practice and one initiative on racial justice competencies. And we'll close out the formal part of the agenda hearing a little bit about the E-Learning Institute Fellowship Program that is run by CDC. And of course, other business comes along, feel free to bring those items up as well. Okay. Have to get my notes back up here on the screen. So our first item is approval of the minutes. Hopefully everybody's had an opportunity to take a look at the minutes. Are there any requests for changes? Correction?
Well, Chair, first, if I may, I'd like to put a motion on the table to accept the minutes in draft form from our June 24th meeting as submitted with a notation regarding their clarity and thoroughness.
Well, thank you, Gary. We always appreciate that. Do we hear a second?
This is John Weisman. I'll second.
Thank you, John. Appreciate that. Any further discussion? Okay, for council members, all of those who are in favor of passing the approving the minutes, say aye.
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 Anybody opposed? All right, super. So now we can start getting into the meat of our meeting today. And as I just mentioned, we've been discussing rebuilding the public health workforce for the past several meetings. And today we will continue that discussion. And we have with us three individuals who are going to help guide us in these discussions. First off, we have Judy Monroe, who's the president and CEO of the CDC Foundation. And for those of you who may not be aware, the CDC Foundation has hired and placed thousands of surge staff throughout the COVID-19 pandemic. Thank you so much, Judy et al., for doing that. In addition to her role at the CDC Foundation, Judy has served as a state health official, a CDC official, and also recently co-chaired an Indiana commission aimed at modernizing the state's public health system. And Judy will be sharing with us some perspectives and ideas about rebuilding the workforce. Second, we have from CDC, Michelle Carvalho. Michelle is the CDC Council representative and also is the lead of learning design and fellowship education team within the CDC Center for Surveillance, Epidemiology, and Laboratory Services. Michelle, I didn't say the entire title because we wanted to move on with the meeting. It's a lengthy title. So Michelle will be sharing with us information about the Introduction to Public Health Practice Training Plan recently released by CDC. And finally, we'll be hearing from Megan Lincoln. And Megan is a public health analyst within the Division of Nursing and Public Health at the Bureau of Health Workforce within the Health Resources and Services Administration. Megan will be talking with us about the regional public health training centers and updating us on their activities. Without any further ado, Judy, I'd like to turn it over to you.
Great. Well, thanks, Ron. And I think we can go to my first slide here. I've got a few slides just to give you all an idea of what the foundation's been up to. First of all, as a bit of background, the CDC Foundation has been in the business of having field staff for a long time, but it's been on a very small scale. So over the years, we might hire 2 CDC Foundation field staff to be embedded at CDC in a laboratory for a project that's being funded by the Gates Foundation as an example, or something of that order. We can go to the next slide. And then it was go to the next slide in terms of the workforce development. So back in 2018, you all might remember that at that time, and it was under the Trump administration, there was funding that went out for the opioid crisis, and states were receiving additional funding to address this crisis. But the states had limitations in terms of hiring. And so they went to CDC saying, there were at least 12 states that went and said, we really appreciate this funding, but we need surge staff, we need specific skills. As an example, one of the skills that they needed were forensic pathologists. They had a hard time recruiting for those kinds of positions and skill sets. And they said, can we get some help? And so the foundation was tapped at that time under our cooperative agreement that we have with CDC. And I remember receiving the phone call saying, hey, can you all hire about 90 staff for 12 states to help with the opioid crisis? Now, I will tell you, in that moment of time for the CDC Foundation, that felt like a big, heavy lift. And I was personally really involved in that because I was on regular calls with health officials and so forth, trying to figure out how we could keep this moving at a pace that everyone wanted it to happen. We learned a lot about the workforce and hiring during that period. What we didn't anticipate was 2020. We didn't realize that was really just a dress rehearsal for what was to come. And the pandemic hit. You can see on this timeline, we were very busy with personal protective equipment in January as this was beginning to emerge. By mid-March, we were getting the sign and the request that there was going to be a need for surge staffing, that the states were not able to do for themselves for a number of reasons, a lot of barriers to being able to hire and do this as quickly as needed. So one of the secret sauces that we did for this was that we hired 10 senior advisors with deep expertise. Quite frankly, it was early retirees that got pulled back into service, but very deliberately were folks with epidemiology background, CDC experience, state experience, public health advisor experience. And so there was this team that was created that in retrospect was really the secret sauce. And we began hiring. And if you'll remember, that was contact tracers that we needed at that moment in time. And so we began hiring all these contact tracers and other positions as well, but primarily that. And by November, we'd hired 847 COVID-19 core is what we called them. So that was, again, a heavy lift for the foundation. Go forward to 2021, we were continuing with the COVID-19, and then the states started coming to us saying, we really like working with the foundation. We like the mechanism. They had received additional funding through the Epi Lab capacity, the ELC funding. And so we had states contracting with the foundation individually for us to be there, to do the recruiting and the hiring and so forth. And then we began in July, there was this bridge. And if you talk to Patty Simone and others at CDC, they were really looking to the need for the future public health workforce, but they wanted a bridge. And so we received funding to hire additional staff. And you can see by 2022, they have 3,000 plus. That 3,000 plus is actually closer to 4,000 in total that we hired. And as of March, we had CDC Foundation field staff embedded in 86 different jurisdictions. That included every state health department, big cities, states, tribes. So we found ourselves in a unique position with a national workforce touching so many of these jurisdictions. If you go to the next slide, I just wanted to give you a picture of what this looks like. So this is the map of the US, and for whatever moment in time, this is as of February of 2022, and it doesn't include all of our hiring, but this is the workforce portion of it. You can see how many people that we had embedded in the particular states that were CDC Foundation, and listed there are the types of positions that were most hired. There were a lot of variety here, but case investigators clearly were needed, data analysts, epidemiology obviously is core, health educators. The health equity officers was again, somewhat of a new request, and that one needs really special skills. And we've had some situations where folks thought they knew how to manage health equity and not so much. And so we need a deep dive and much better training, I think, for folks that are leading health equity. We can talk more about that. Public health attorneys was an area that a number of states were desperate for public health law and attorneys that could help them navigate some of the situations they were finding themselves in. The school liaisons, we hired a ton of school liaisons, particularly in the state of Michigan. And that was when we had vaccines available now to school age kids and kids going back to school. That now is quieting down. That jurisdictions came back saying we no longer need those. I think shows the particularly in a pandemic, but in any emergency, how there are certain positions that may be needed in public health, but not for the long haul, community outreach workers and so forth. Next slide. So the next slide shows a little bit of our overdose response strategy. I wanted to call this out because going back to the opioid crisis, one of the things that became apparent was that public health was working over here on the opioid crisis. You had law enforcement working in their world, and they had two very, very different cultures. And I can remember being in DC at a national meeting, and in the Uber ride with others from CDC and so forth, we were problem solving this. And what we ended up doing was hiring field staff that were public health that got embedded in law enforcement with special training to be able to do this work that was needed. So again, kind of a new need for the training in public health to meet this need. And there's a 13-member national coordination team that kind of oversees this work. And then the last slide here just shows you our footprint with our current footprint. I think this goes through July. Yeah, this is a current map. We have 155 search staff working on the overdose data to action project in 55 jurisdictions that includes subrecipients. So just to give you a flavor of our footprint and what we've been involved in, I think that's my last slide. So to talk a little bit about the insights that we've gained thinking about the public health workforce, one thing I would say to start with is this, and I'm going to start with the inspiration side of things. We found ourselves in this really unique opportunity with this national workforce that we could communicate with on a regular basis. They had supervisors that were our staff, and then they, of course, were they got their daily direction from the health departments and worked on a daily basis with the health departments. But we had this opportunity to create sort of an esprit de corps. And so every week we would be communicating. Every Monday, all the staff got a message from me talking about the importance of the work they were doing, even regardless of what job they had, how that position was so important to the larger mission. And I will tell you, that really helped us a lot. I mean, I think folks found the fulfillment and the inspiration. And I wanted to read to you as an example. We just had this come through yesterday from one of the individuals, the young man that we had hired. And he sent us all a note saying, my entire working career has been filled with a range of responsibilities in sales, banking, real estate, and management. However, my work with the CDC Foundation has proven to be the most rewarding. I believe that giving and helping others continues to make us all happier and healthier. So I wanted to start with that because I think we have a huge promise, and we've seen a lot of folks coming in to help with the pandemic that have found public health to be quite exciting. Now, on the backside of that, however, we all know that the funding situation is a major challenge, and this need for multi-year sustainable funding to be able to staff up. And this is an area that we've taken on with the Indiana Governor's Public Health Commission, looking hard at the state level. We've got challenges at the federal level, and it's quite challenging to get the sustainable funding for public health that's really needed. But the states also need to step up and do their part as well. So in Indiana, as an example, our recommendations from our commission range all the way from the pipeline that there should be paid internships and scholarships, loan repayment, those types of things, to shared staffing to get broader experience from businesses in the community, working with health departments. We obviously need a diverse staff. We've talked about a state health workforce plan is one of the recommendations, and that public health needs to be at the table. As an example, in Indiana, they have a GME board that and a governor's workforce cabinet. Public health needs to be at the table. They should be part of that broader workforce looking at healthcare and public health across the board. And then there need to be reporting measures that should take place. One of the things that we did ask for in our commission is additional funding at the state level, sustainable annual funding coming from the state to be able to not only hire more workforce, but to also pay them more and to have studies done on salaries. So I want to tell you another lesson we learned in this, and because we were hiring short term, all those staff you saw on the maps, hiring short term, we did pay, the foundation was able to pay, in some cases, a little more than the states. And let me tell you, that created some tension. And states, I got plenty of, I got phone calls saying, hey, you're paying more for the epidemiologist. That, by the way, they couldn't find anybody to do the job, but we found somebody and we hired them. And so my answer back, I would listen respectfully, and then what I answered back was, well, first of all, we're hiring short term, and typically there's a premium if it's short term and not long term. But I said, quite frankly, I think we're paying more fairly and you're not paying enough. So why don't you use the tension that we have now created by hiring field staff in your health departments? Why don't you use that tension productively to try to increase your salaries. So I'm happy to report that Kathleen Toomey in the state of Georgia did just that. And she successfully got increased state funding to increase salaries in Georgia for public health. So I do think we need to be smart about the political environment and where the funding comes from and how we might leverage certain moments in time. So that's one lesson learned there. The diversity of staff is another area. We ended up hiring quite a diverse staff, but one of the things I just listened, I had an opportunity to hear Marlee Matlin speak. She's an actress, activist, and author, but she's deaf and has had a very illustrious career. But she called out that the DEI is missing the A, that it needs to be DEIA, and the A being for accessibility. And I think when we look at the public health workforce, if we really truly want that diverse workforce, I think public health, like other areas, need to look closer at the details of accessibility for that diverse workforce that may have particular needs that we've not thought about before. Another area I would call out that we have encountered, and I know all of you all are struggling probably as well, is this new world post-COVID and the hybrid workforce. I think we need some additional training and thinking about how to work in this hybrid. What is the right mix of in-person versus folks working from home? I think everyone's concerned that you're going to lose, and I think you will. I don't think you're going to have workforce if you don't allow them to have remote, some work at home. But what's the right mix, and how do we do this in more constructive ways? Because I do think we've lost some things with the remote work that we've all done. And then other lessons along the way that both from the Indiana Commission as well as the hiring of our staff that I would call out is the need for the new skills in public health. I actually just last week, Stat News published a piece that I wrote on the lessons that we might learn from NASA for looking at public health. And NASA, of course, underwent over the years a number of things. One, of course, they started putting in front of the public the value of what they were doing in space and how that translated into what's happening here on Earth and so forth. But they also re-envisioned and went from a hierarchical organization to one that is flatter and works with the private sector differently. Public-private partnerships have really been revitalized, and all the things you're seeing happening now are because of those major changes. I do think public-private partnerships is an area that public health training needs to be addressing in a more intentional fashion and building a skill set that we don't have across our full workforce. Communications. I mean, that's one that has been a major challenge. I had meetings last week. I was in New York City for UNGA side meetings, and I had several meetings with Meta. And it's really interesting when you talk to the organizations that have the large databases and are out there. They have 3.5 billion people that use their platforms, right? So it kind of boggles the mind. And they made a comment to me that really struck me. They were talking about, in this case, it was a CDC tool that had been built that they thought was really fantastic during COVID. And this particular tool was being used by or 1 million people that maybe had accessed it. And their response to that was, is that all? Is that all? Just 1 million? And so I think we need to think about scale with our workforce skill set. I think that's an area, and obviously in communication, folks need to be able not just to use plain language, but to use all the variety of communications. Data is one that obviously is one that we need new skill sets that I know you all are quite aware of. And then, but with communications, I think comes a need for additional training in folks in public health being politically savvy and understanding the political context in which public health practices and having less fear I would say. I think there's we get hammered a lot in public health, but it's not a time to be fearful and step back. It's a time to be smarter in how we communicate, what languages we use, what relationships we build, to be able to advance the critical needs in today's world. So Ron, why don't I stop with those initial thoughts and see where folks want to go, maybe with questions and dialogue.
Great. Thank you so much, Judy. And I would encourage people to ask questions orally or in the chat box. And also any comments, observations, experiences that you've had around successes with recruiting and retaining public health workers would be quite valuable for colleagues on this call to hear. One thing I'd like to mention, Judy, was hearing what you were talking about, the skills and competencies that are needed. I was delighted to hear that you hit upon, most of the new pieces that are within the core competencies for public health professionals. So that provided a little bit more validation for us that we indeed have been on the right track with that. So thank you. And Gary, I see that you have your hand raised.
Thanks so much, Ron. And Judy, thank you for the excellent overview. A lot of important elements placed before us today. I want to go back to partnerships, and you mentioned public and private, but I'm wondering about the salience, the ability for partnerships to continue given the ramifications that we're facing from not only COVID-19, but the lack of exposure experience to influenza in the last season. You put those two together along with other infectious diseases, and we're not out of the woods yet. I think many would concur. But the partnership that I'd like to ask you to speak about has to do with the investment in public health and healthcare practitioners, which obviously is very front line. And quite frankly, I get concerned about that front line receding with a more laissez-faire approach coming into the early fall. But who knows what awaits us later in the fall and into the winter season. So salience for public health, healthcare partnerships.
Yeah, no, thanks for that. So I've been a strong believer for I'm a primary care physician by training, and I directed a residency program prior to coming into public health. So I was on the healthcare side, then found myself on the public health side. And so those partnerships to me are absolutely critical. I will tell you what I didn't mention. I was talking about our workforce, but one of the things we did during COVID at the foundation is that we found ourselves both with public and private funding being able to support a number of community-based organizations. And we required, when we funded a CBO, we required that they have a connection and relationship with the local health department or the state health department, depending on whatever was appropriate. We sort of forced, if it wasn't a natural, we wanted that relationship to take place. I think the same thing needs to happen between healthcare and public health. I think we need to be more deliberate about those relationships, especially facing things like you're saying with the influenza. We're not out of the woods in a number of these areas. I do worry about the mental health of both workforces as well. I've had some conversations. We're in conversation with one partner, a new emerging partner for the foundation, and they're one of the groups that they hire about 25,000 physicians, emergency physicians, anesthesiologists, that type. Their ER docs are just, they're really fraught with the challenges that they're facing right now. And between ER visits and we all know what drives some of the ER visits when we don't have the primary care, we don't have the systems in place. But I'm quite concerned about that coupled with the public health. So I think we need investment in and be smarter about our mental health support. But one of the things that fascinated me talking to this group is, as challenged as their physicians are, the physicians are looking for meaning. They're looking for meaningful work. And one of the things that reinvigorates them is maybe volunteering or doing things, but they need specifically to know what to do. So I think there's a marriage there with public health projects in communities and that might forge relationships in a unique way that actually could lift all boats. and be inspiring as well.
Yeah, excellent, excellent. I support the direction that you're going in. Thank you.
Thank you.
So this is Amy. I'm watching the chat, and it seems like there are some comments and some questions for Dr. Monroe. First is a comment saying that folks are also using DEIBA, diversity, equity, inclusion, belonging, and accessibility. And then a comment from Jim Adams from Canton, Ohio. Hi, Jim. And he was just saying that Canton's a medium-sized city in Ohio, and he's also a former Hauser from Huntington, Indiana, and he thinks you're right on point. Canton's been lucky beneficiaries of 2 CDC Foundation employees, and he thinks it's an amazing program. And he said he can go on and on about how positive the experience has been, and he just wants to thank you so much for helping making this possible. And Shelley has a question on, did the CDC Foundation do any recruiting for public health nurses as part of your surge workforce?
Yeah, thanks for the question, and thanks for the appreciation. It was a labor of love. Let me just say that, because of the folks that we brought together on our team, they were so committed, and they on the recruiting side in general, I got to tell you, I mean, we had epidemiologists that would look at the applications of EPIs going to health departments. And they go, no, we need to make sure that we get even more qualified applicants. I mean, folks really cared about who we placed. Public health nurses, we did. And nursing, we actually hired some clinical nurses as well as for practicing public health. And so this was an interesting nuance. With federal funding, we could only hire folks that did practice public health. With federal funding, we could not hire anybody that did clinical work. However, we were fortunate enough during the pandemic to bring in some private funding, and that private funding allowed us to hire clinical expertise. So we hired a number of nurses actually through, that was probably the bulk of who we hired through the private funding that we received that was part of this workforce.
So, Shelley, did you have a follow-up question on Dr. Monroe's answer?
Nope, that's fine. That was all I wanted to know.
Okay, thanks. There's a couple more comments, and then I see Jim's hand up. So I'm just watching the chat here. So Dory says that she serves as director of applied practice for the University of San Francisco's MPH program. They have coursework on public health policy and ethics, as well as communications. And says, I see some students struggle when encountering diverse political positions when doing their field work. How can they better prepare students to manage this? And also there's a couple of people who did their undergrad at University of San Francisco. So.
Yeah, well, thanks for the question. I have to tell you, I've had, actually, we've had a couple of alarming situations that have crossed my desk with our workforce. I alluded to this earlier. We really do need to do a better job of preparing our workforce for diversity, working with diverse populations, but also in a diverse workforce. There are some, there are tensions, right? I mean, we've got to be honest that folks come to this with different mindsets, and I think you have to start by first understanding where their starting point is. I'm a primary care physician, so I can remember being taught and teaching that you always begin where the patient is at, right? You don't begin where you want them to end up. You begin with where they're at, and with a deep understanding of that. And so that would be the first thing I would say. And maybe in our trainings as well, we need maybe the tools or the right way to first understand who the students are, who the new workforce are, where they're coming from, and being able to address either their biases or their strong feelings. I mean, there's some pretty strong emotions out there before we can bring folks together to approach some of these issues with diversity like we all aspire to have, and that acceptance.
So I wonder if we could go up to Jim, who has his hand up, and then go back to chat.
Hi, thanks for letting me just kind of jump in. Dr. Monroe, I do want to just kind of reiterate how successful I think this project has been. We're the recipients of 2 foundation employees, one a school liaison, another epidemiologist. The quality of the individuals has been outstanding. Two real quick observations. One is the school liaison individual was on a career path to be a clinical counselor. And because of her experience with the local health department, has had an epiphany and wants to switch and make her career in public health. And I think, just that exposure, like you mentioned before, just that exposure to public health as a possible career path can be life-changing. I know it was for me 45 years ago when I started. I had no idea what I was going to do, but I'm glad that I went with public health, and it's been a great career. The other part that I want to mention is that our staff is extremely busy doing the things they had to do to help recover from the pandemic, and could spend little time in onboarding new staff. So your Monday meetings with the CDC Foundation folks really helped enculturate them into the public health mindset, and we didn't have to do that. And that was very, very helpful. And I just hope, this is a great model for how we can approach staffing surges and staffing shortages in the future as we modernize our public health system. So thank you.
Yeah, you're welcome. I've actually been approached. Some folks are interested in whether this could be replicated globally, because other countries need the same ability to surge. But I think you hit on a couple of things. One, I'm thrilled about the epiphany, and we've heard many stories like that. I mean, where folks came in, it was their first exposure to public health, and they love it. They just love it. So we have a real positive there. The onboarding, that part. When I was at CDC, I had the opportunity under Tom Frieden to help build out the public health associate program. And so that was my starting point with when I realized, gosh, we've got this national workforce that are our employees, but are supporting the health departments. I took some of the lessons from the PHAP program, which was national, and our team did lean in. So I appreciate you confirming that model of actually, it's a model for being able to bring a whole national workforce together with that, learning the culture and learning about public health in mass is kind of an interesting experiment.
Yeah, and my last observation is the new staff that we brought on, and we've probably had more than 40% of our current staff now have been with us less than 3 years, and out of a staff of about 74 people. And the new staff that we brought on have just this amazing positive attitude. They bring great new ideas, interesting ways thinking about how to organize and do their work. So all the conversation you've had around remote work and hybrid work and all that is certainly right spot on. But I'm just really excited for what the future of public health brings with this new crop of individuals.
Yeah, that's terrific. No, there's a lot to be optimistic about.
So back to the chat, Tally Schiller has a question on, has anyone worked on an apprenticeship program or a model for public health workers, for example, apprenticing with a public health professional for a period of time to train them for a job? Michelle has responded with AmeriCorps, but Dr. Monroe, I was wondering if you had any thoughts on this one as well.
Yeah, so I think that hits on some of the things that we've talked about here in Indiana is models for that pipeline. And I love the apprenticeship model. I personally, I think, we do have a rich asset in our country of folks that are either nearing retirement or the early retirees that can be mentors back, and then certainly embedding young folks. One of the areas that the foundation is taking on now, and this around climate and health and some of the other areas, we're beginning to lean in to youth engagement at the foundation. We believe that there should be, so I'll go ahead and as an example, CDC has had a disease detective camp for a number of years. Some of you may not even know it exists. It's been only at CDC. Why isn't that national? Why don't we have a CDC disease detective camp in every city, in museums, in schools, right? I mean, really fillet it open so that high schoolers can see the opportunity for public health, and then those apprenticeships, build those at that local level, begin to build those out. So I think there's a whole array of exciting things that we could do that actually are quite doable if we put our minds to it.
Thank you. Ron tells me we have to wrap up this conversation. So back to you, Ron.
Thank you. We could go on. And Judy, when we were planning the meeting, we thought we didn't have to worry about there being questions. We knew that there would be. And thank you so much for engaging us in this discussion. There's an incredible amount for us to all share on strategies around recruitment and retention. I'm thinking yesterday I was in a Virginia Department of Health meeting, and a lot of these same concepts came up. And people are trying all sorts of different strategies. And that was one key message we had, and that was try, and try, and don't let the perfect be the enemy of the good. And we can use quality improvement methods to improve along the way. So Judy, any final words?
Excellent. No, just thank you all for all that you all are doing. Great to join you today.
Great. Thank you so much, Judy. Okay, so now we're going to turn the conversation over to Michelle to talk with us about the CDC Introduction to Public Health Practice Training Plan, which of course addresses some of the comments that were raised about people not being public health trained coming into public health. So Michelle, let me turn it to you.
Great, thank you, Ron. It was really exciting to hear the discussion and hear all of vision that Judy Monroe shared. I think this plays right into what we're about to talk about and drilling down into some specific tools. And to give you some context about all our long acronym names, Judy mentioned Patty Simone and her work with the public health workforce. So Steve Reynolds spoke to us last meeting about the infrastructure grants. He also oversees Public Health AmeriCorps work. And so this all that I'm about to share feeds into that because we're all in the same division of scientific education and professional development. So we're really excited to hear some of the cross bridging. Our division also tends to be one of those that bridges silos. So we're not focused on any specific disease. It's more on specific skill sets and workforce development. And so part of the story that I'm going to pick up off and share is from a teaser that I gave last meeting. And as a recap for those who weren't there, we at CDC, we work closely with Public Health AmeriCorps partners on a learning strategy for their public health training for new members. And we cloned and adapted that training, which is in CDC Train. We made it available as a public-facing plan called Introduction to Public Health Practice. So I know some on this call might remember Kathy Miner, who I worked with before she retired. And she used to say there are thousands of public health 101s out there, and how do we figure out which ones we're pointing people to? And many are very specific to local areas. So we had the task within about a 7-month period to try to curate what exists now. Now we know there's a lot of training content that's being developed. And so what we set out to do for Public Health AmeriCorps was to curate the existing best trainings we could find that were appropriate to this entry-level new practitioner that may have never heard of public health and may be new to it. So AmeriCorps has an infrastructure that's already built for bringing in interns and fellows and that type of internship experiential learning. And so we're tapping into their infrastructure. And I put in the chat, someone mentioned earlier about wanting to know about structures and frameworks for programs. So they have a current group that's funded now and another funding announcement that's open. And so how this is relevant to this group is that this Introduction to Public Health Practice, now that it's free and available on Train, anyone can use this. If they have their own training plans or criteria for health departments or local settings, that's fine, but this is more of a free resource you can pull from. Many of them are already existing in CDC Train, so you can also create your own training plan if you have trained administrators, but this one is optional. So one of the main differences between the Public Health AmeriCorps version and this one is that AmeriCorps has about 16 hours of required training in this, whereas we have hashed out a little bit differently. And I mentioned these 8 sections in our plan. Some of them are based on the Council on Linkages Core Competencies. So I had the honor and benefit of being on part of the working committees and with Amy Lee in the health equity domain. And so we really use that in our planning and curation process. So next slide, I just want to give you a quick view of what it looks like in CDC Train. So I mentioned that at the very bottom, you'll see there's getting started content. In the AmeriCorps version, that's required content. And the further exploration content, there's about 17 hours of that. So people can choose from a menu of what's most relevant for them. And host sites or mentors can also choose and help their new fellows or interns choose what's relevant to fill in some of their training gaps. I briefly wanted to mention that we use a curation process referring to CDC's quality training standards. And we also use the Public Health Learning Navigator standards. And two of our staff members spent quite a few hours and months curating and reviewing many, many trainings to get to this point. We were also trying to fulfill AmeriCorps' needs to keep this under 20 hours worth of training. This is to be spread over months of their internship. So we were trying to keep it brief. So it's not meant to be extensive or comprehensive, but to give them an overview for each section. So next slide, I'm just going to give you a glimpse of a few of the domain or sections in here. So the introduction not only has a few courses that come from other places, but there are also videos that are meant to be kind of inspiring from different practitioners, giving a view of what they do in public health. So some of them are really short. You can see there's like even a 0.08 hours. That's how Train organizes the time, but they're meant to be short videos, but we've added reflection questions so they can go back and be reflective practitioners, think about what they learned, and maybe even go to other people in a health department or nonprofit that they're working in to learn from their experiences. And you can go to the next slide. So we do have a health equity section. Judy mentioned the need for depth in training on health equity. These were just a few of the overviews. So we're just getting at the very tip of the iceberg of health equity training. And we have some that we have curated that are on our list for those that need deeper training in health equity, but we are working with partners to determine what's already out there, who's already developing some content. Some that we didn't choose were really good and interactive and quality training, but the terms were outdated. So we're constantly looking to partners to see what you're developing and want to learn more. And then there's a whole large section on communication skills, which also refers to one of the priority needs that Judy mentioned. I won't go through all of them, but I did just want to point out certain sections that might be of most interest to you and your networks. And the last one, I think I have one more. So the last section, which was very important for AmeriCorps and I think for all of us, is that once we have interns, fellows, new people coming into public health, that we give them options for where do we go from here? What are some career options? So some of these are also curated videos from different places. It might be schools of public health, professional organizations. I think we have some from NCHEC on health educators. You can see there's some of what does an epidemiologist or a program evaluator do, and then some next steps in public health. And I believe we have linked to ASTO's new website and careers in public health as well. So again, this is a starting point. We had to curate a lot of content in a few months. And so we do have a round 2 of this where we are working with in a cooperative agreement with partners to curate new enhanced content and link to other things that your groups are doing around the country that might strengthen the new public health workforce as we expand. So I will pause there and also point to the link I put in the chat about Public Health AmeriCorps, where they do have a link to their current sites that are hiring now. So if you have public health students looking for internships or jobs, and there's the NOFO or Notice of Funding opportunity for new sites, and we would like to reach out farther and maybe even to non-traditional partners to host Public Health AmeriCorps members. So hopefully this will be useful just across the board if you want to pull from it, get ideas. That's why everything's optional. So you can pull from it and tailor to your program needs or your network's partners. So I'll stop there and see if there are any questions or comments.
Thank you so much, Michelle. Any questions or comments? I do have one comment, one thought. And probably you've already thought about this. Yesterday, I learned that Virginia alone has 28,000 Medical Reserve Corps volunteers. Many are not familiar with public health. And granted, they're there for preparedness, but you really can't or shouldn't separate preparedness from public health. And I'm just wondering if there's an opportunity there to be working with the Medical Reserve Corps and making sure that they are aware of this wonderful new training plan.
I would say that that is a promising direction to look if we link partners. And if the Virginia, I can't remember, do they have an affiliate train? A train
Yes, they
affiliate?
do. Mhm.
So that I think is a perfect opportunity to talk to their train affiliate, because if they're linked to their train administrator, which I know you and Kathleen know more about, that they could create a tailored plan for that particular group, or at minimum point out specific courses that might be useful to them, especially since they're, for everyone's time is limited. So they might be able to say from this plan, what are the high points? And I would say an introduction might be helpful
Great.
for that group.
Great. Yes, and there is Medical Reserve Corps train as well. So individual units can do that. So thank you. So letting us know that they are permitted to do that is great. We'll be sure to spread the word.
So Allison said that she was one of those and it was a great experience during COVID, but Dana has a question and she says, can these modules be completed by our high school students? Oops. Screen just flipped. High school students as a part of our promotion of public health careers.
Absolutely. This is completely free and open to the public. They just need to create a train.org or CDC train user login and password, but anyone in this is completely open and free, public domain. And I believe all of the trainings that we've pointed to are also free and open and public domain. To point out, I know Megan's coming after me, that at least 5 of the public health training centers have courses that populate this training plan as well.
Yeah, Michelle, I was looking this morning, and a lot of the trainings within the training plan have been very, very well reviewed by learners. So that's good to see as well.
I will say that my team members that are the reviewers were very systematic and fairly strict about what they inserted and have rationale for the ones they didn't insert. Not that they weren't great, but they may not have met a specific need at the time. So I appreciated that sometimes I would throw trainings at them and they say, well, we already eliminated that for this, and this reason, just for this one, maybe a future one. So they have been pretty strict on following their eligibility criteria and their process.
Well, it's proven to be a success. Gary, it looks like you have a question, and then I think we're going to move on to Megan.
Thank you. Michelle, a great overview. A quick question for you regarding certification. Obviously, the sources of these various training modules are coming from various organizations. And I'm wondering if you're seeing an upsurge with these modules actually accounting toward various types of certification, or and also would be encouraged by the CDC over time. I would hope that certification options and opportunities would be readily available and considered a priority. I'd be interested in your response.
Sure, and I will use the word certifications with a caveat that some people are defining them in different ways. At the highest level, professional certifications with CE, CMEs. As far as this, we couldn't do a certification in that in CE sense for the entire plan as it is, because we didn't develop. And as you know, CEs have to be developed from scratch with a committee. However, some of these, one is an example that I believe if it's not added now, should be in the next 2 weeks, is CDC's health literacy training that does have CEs attached to it. There are several in here that do have CEs, CMEs attached. Our same branch actually takes care of all of CDC's CEUs for 9 professional organizations. So that I can say pieces of this have CEs attached, others don't. Some groups like NCHEC for health educators and CPH will accept certification as long as you have documentation of learning objectives, all of which these do have learning objectives that you would just need to provide proper documentation. This training plan will not generate one certificate. Certain courses will generate their own certificates, but you can generate a transcript of completion from CDC Train. So that could be used for certain groups that will accept that for CEs. And part of our year 2 plans are to think about if there are ways or components that could create some sort of certification or incentive for new practitioners who want something more than a transcript. So we are brainstorming that. Did that answer your question, or are you going in a visionary direction with that question? Because it does sound like something we could consider.
Yeah, always having that as an option because what we're talking about are skill sets being developed, and these cover such an important array of possibilities. I'm glad that I'm hearing in your response it is a priority, and you are continuing to look forward to have even more opportunities. And yes, module by module related certification, certainly not across everything.
Excellent. Thank you for the idea.
Well, Michelle, thank you so much. And I just want to address one of the comments I saw in the chat box about sharing this with high school students. That's something that we absolutely can do. And we've actually done some of that in the past, but this is definitely an opportunity for us to share the wealth, and as part of recruitment into public health is a really good idea. So we will look into that as well. And thank you so much, Michelle.
Thank you.
So to continue the excitement, we now have Megan Lincoln, who's going to talk with us about the regional public health training centers and some developments there as well. Megan.
All right, next slide, please, Kathleen. And again, I guess I'm Megan Lincoln, as I've just been introduced, and I am with the Public Health Training Centers here at HRSA in the Bureau of Health Workforce. I'm just going to give you a brief overview of the work that HRSA and the Bureau of Health Workforce do. This is from the last grant cycle that just ended. The new one has just started. It's a 4-year cycle from 2004 to 2006. So the public health workforce is a cooperative agreement with the public health training centers. And the agreement is to meet the state, national, and local healthcare needs. Our program has increased the number of quality and the ability of the public health workforce. It funds 10 regional public health training centers, one in each of the HHS/HRSA regions, and provides graduate and specialized training in public health. The centers operate from public health schools and programs, and the training helps public health students and workers develop technical, scientific, and leadership skills. The academic year of 2020 to 2021, the program supported 408 trainees. 32% of them were from an unrepresented minorities, and a majority, 62% of the students training took place in the medically underserved communities, which is one of the big targets for us here at HRSA, is the medically underserved communities. You'll see that there is a fiscal year 2021, 17 million. That is not just the public health training centers. The public health training centers receives 9 million of that. The rest of the money goes to the public health residency program and the new public health scholarship program. A little bit more detail. Next slide. The next slide really talks about what is new in this next round for the public health training centers. So in fiscal 2022, we looked at what was working with the public health training centers and what we could build on and meet the emerging needs currently happening in the public health workforce. We wanted the public health training centers not only to focus on training on their local needs, but we wanted the trainings to address the fundamental and cross-cutting skills and knowledges needed for the public health workforce. So we're requiring the public health training centers to align their trainings to support the public health core competencies. In the last round, we asked them to. This time we were telling them to incorporate them. As we saw during the pandemic, some of these core competencies were really needed in the workforce. Each center is also to establish a public health leadership institute. This is to support the emerging, to support enhanced training for the diverse cohort of public health and primary care leadership, emphasizing again the core competencies. Dr. Gilmore, I think you asked about primary care earlier. We have heard that need and are trying to reach that in the public health institutes. Again, also, not just in the Public Health Leadership Institutes, we're asking the public health training centers to link with their primary care associations and trying to strengthen the primary care associations with their knowledge on public health. Again, not just through the institutes, but also working with them outside and helping with the development of training there. We are also trying to address the lack of preventative medicines doctors in public health by encouraging public health residents to participate in the public health training center student placement programs. We are also, which is in under the student placements, we're also trying to do health equity with the student placements and looking at tribal land and in the U.S. Pacific Islands and allowing students in community health center or community college programs to have student placements, as in for tribal lands and tribal territories and in the U.S. Pacific Island, the workforce seems to be more people with associate's degrees or bachelor's degrees. And that is really, you can go to the next slide if you want, is really questions. That's really what is new with the training centers this go round, opposed to the last few, if you have any questions or anything.
Thank you so much, Megan. And it's, it's great to see the continued activity and support of the public health training centers and their use of the core competencies as well. Are there questions for Megan? I don't see any questions. Okay. Oh, I do see a question now. John, please chime in.
Hi, Megan. Thanks for that. Hey, can you say a little bit more about the Leadership Institutes in terms of what's expected of them? Are they each taking sort of different frameworks or focusing on different populations? Anything more you can just say about the Leadership Institutes?
Yeah, so each region will have one. 3 regions currently have one that have worked in the past: Region 10, University of Washington; Region 4, Emory; and Region 7, University of Iowa. And it's actually a Nebraska Leadership Institute, and Nebraska is just going to open it up to the other states. Each training center will look a little different depending on what the needs are in their region and what their focuses are. Usually, Iowa does a lot with tribal relationships in rural communities, which will not necessarily happen in the other institutes. University of Washington, Emory, and Iowa have been doing this for years, so they have strength and everything. Other training centers are just going to be starting in year 2, where they're right now developing what their curriculum and everything. The programs are usually last 12 years or 12 months in most cases, and they are usually a 1 or 2 day a month activity. Some require a project, but usually they have found the projects don't die off after the cohort is out. So there might not be projects. Again, depends on each program. They're really looking to get a diverse group in there, the diversity in each state that comes in, what the state demographics look like, getting again a group of both primary care physicians and public health officials in there, both at the mid-level and the higher level, tier 2 and tier 3 levels. And what else? So yes, the frameworks will be different depending on the region. The great thing about their training centers is they work very well together and they're not competitive with each other. And so they are actually working together to help. The older centers are working with the newer centers to help develop something. And I can send in, I wonder if Ron and Kathleen would not mind help advertising when they go out. They usually advertise through me and through each training center's newsletters.
So
I realized I was on mute. Megan, we're happy to do that.
So I'm sorry, go ahead.
Megan.
Yeah, there's a chat question from Lloyd, and he says they have a meeting at 2 p.m. today, but he was wondering if there's any message that you would like sent to PC primary care. Lloyd? PC primary care, is that?
Yep.
Yes,
Yeah,
primary
so
care.
Yep.
And Lloyd, actually, the training centers are meeting next Thursday with the Northwest region. Is that what it is? Northwest Region Primary Care Association?
Oh, great starting point.
Yes, and the Northwest Primary Care Association in Region 10, University of Washington Training Center, the Northwest Training Center, they actually collaborate in their Leadership Institute already.
Yes, they
So
do.
Yes, so that's where they're going to start. That's the first meeting is on Thursday, and the Northwest Primary Care Association is coming in and meeting with the training centers.
So would it be appropriate
yep.
or inappropriate to let the primary care groups know that this may be coming to a region near them, or is that premature?
No, that would be wonderful. We're also going through the PCAs here at HRSA to advertise it, but yes, we would love it and everything and
Done.
everything.
Thank you. This is fantastic. Thank you. And great place to start.
Yeah.
Great. And I see, Gary, I'm going to have yours be the last question. We're falling a little bit behind schedule. Lots of great comments and discussion.
Yeah.
Also, if Megan could put a link to the main HRSA website in the chat, that would be great too. So as you're listening to Gary's question.
Yeah.
Yeah, a great stimulating foci being discussed today. Megan, I want to pick up on something that you mentioned about selected training centers and more rural health focus. Let me just give you an example, which you're well aware of. Broadband is continuing to expand in rural settings, and we're placing a priority on that in Wisconsin and some of the other parts of the Midwest. I'm wondering if this is being prioritized. Are you seeing a growth in rural focused activity, and are more training centers in the queue on that?
So that is one thing that we're trying to, again, emphasize and get in this next round is the rural area. Region 7 and Region 9 or 8, Region 7 and Region 8 are strongest with those rural communities. Region 7 has a lot of trainings targeted towards rural communities and working with rural communities, and has also been working with the other training centers to help bring in that rural approach and everything. And since the trainings, even though they are region specific, or the needs assessment have taken place in those states or in that region, they do cross over to different states. So I would really look into Region 7, University of Iowa Region 7 Public Health Training Center for rural trainings. They're really great and strong that way. Again, also with broadband and the extending thing, they are also looking into Project Echo, and the training centers are collaborating so that they could all get trained in Project Echo. Right now, Region 8 is the strongest in Echo, but all the training centers will be trained in Echo and hopefully be able to utilize it in the next year and moving forward to reach those rural communities and get those trainings, those personal trainings out there.
Outstanding. Thank you so much for your efforts.
Not a
Great.
problem. Thank you, guys.
Thank you. And I'd like to thank again Judy and Michelle and Megan for really leading this discussion on rebuilding the public health workforce, and for all of you who are participating today for your comments and discussions and ideas throughout. Very, very informative and I think helpful to us as a community. As you know, I believe, as you know, between council meetings, the work of the council continues. And so I'd like to turn this over now to Kathleen Amos to talk about or to update us on the activities of the academic health department and learning community, as well as what's going on with the core competencies for public health professionals. Kathleen, it's all yours.
Thank you. And thank you all. This has been a really fantastic discussion. I'm going to try to keep my remarks really brief because I can obviously email y'all at any time. And so if you have any questions about any of this stuff, just let me know. But we just wanted to share some quick updates in terms of where we are with the academic health department learning community and the core competencies for public health professionals. So many of you have been here before and have seen this slide before, but really our academic health department learning community is sort of that national community that brings together and supports practitioners, educators, researchers, and others to really explore this idea of academic health department partnerships or formal partnerships between health departments and academic institutions. So that community is wide open to anyone who'd like to participate. We do have more than 1,200 members participating in the community at the moment, and the community engages in a variety of activities to kind of share and learn from each other. So we have webinars, we build tools and resources. There's a listserv so people can ask questions, and we're happy to answer questions at any point as well. So we do track, as we have for many years, and those of you who are well familiar with the council have seen these kinds of data before, but we do continue to track engagement with the learning community, and that continues to grow. So far this year, we've had more than 7,000 visits to our online presence, which brings us to over 80,000 visits since we launched the learning community in 2011. We also continue to receive requests for assistance, discussion around academic health department partnerships. And so far this year, we've responded to 15 requests serving organizations in 10 states and the District of Columbia. So 11 organizations total. We also continue to engage in conferences and things like that to help spread the word and stimulate discussion about AHD partnerships. So we did participate in the National Association of County and City Health Officials, the NACHO 360 conference this summer, where we did a session on envisioning and building the public health workforce of the future through partnerships. So that session really provided an overview of what academic health department partnerships are. And then we had two great speakers from local health departments join us to talk about their experiences with these partnerships and how those all came together. In addition, we are currently planning the next webinar in our HD webinar series. So we have kind of this ongoing webinar series that we host through the learning community. So we're in the process of just putting some final touches on that and solidifying the date, but we anticipate we'll have our next webinar towards the end of October or early November. So as soon as we have the details, we'll be sharing those on our website. We'll share them directly with the learning community. We also send it through the Council on Linkages update. So we'll make sure that you all get all those updates on that webinar. So that's all I'm going to say for the moment around an academic health department partnerships. We do, as always, have lots of information about the learning community online, or please definitely feel free to reach out to me. And I'll pause to just see if there's any questions here before I give some quick core competencies updates. And I know there's been a ton of discussion about this in the chat already, so feel free to continue to have that dialogue as well. Lots of great ideas around these partnerships and internship programs and things like that.
Great. Well, Kathleen, you want to move into core competencies?
I would love to. So similarly, we'll just share some quick updates on the core competencies for public health professionals, which as those of you who have spent time with the council know, are a consensus set of foundational or cross-cutting knowledge and skills for public health professionals. All public health professionals, whether you're engaged in the practice of public health education, or public health research. And these have been around for more than 20 years now. They first came out in 2001, but do go through a regular review and revision process. So the current version was adopted by the Council on Linkages in October of last year. The core competencies continue to be widely used to support workforce development across the country and support a variety of different activities within workforce development, things like building out job descriptions and performance objectives, looking at competency assessments, which have been really key for accreditation, and then building workforce development plans. As Megan mentioned, the public health training centers and others build a lot of training and education around the core competencies. And they also support the development of discipline-specific competency sets and other kinds of resources. They are integrated also into national initiatives like Healthy People 2030, which focuses on increasing the proportion of public agencies that use the core competencies in continuing education. As I just mentioned, they are built into accreditation for health departments as a resource that can be used as you're doing your workforce development planning. And the core competencies were also one of the resources used in developing the competencies that you see in the accreditation criteria for schools and programs of public health. We've talked a little bit about the Train Learning Network, especially with the introduction to public health practice training plan, and the core competencies appear there as well, so that people can search specifically by those particular knowledge and skills. And the core competencies are designed to align with the essential public health services. So with that little bit of background, similar to the academic health department learning community, we do track engagement and usage of the core competencies. So far this year, the core competencies and the various resources and tools that live on the council website have been accessed online more than 72,000 times, which breaks down to slightly more than 38,000 visits to the core competencies, that webpage that houses the core competencies itself. And an additional 34,000 visits to the resources and tools that are available to support use of the core competencies. We also, because the new version just came out last year, have been tracking visits to the webpage, specifically since we released that new version, and we're looking at really close to 45,000 visits to that webpage as well. Similarly, we answer questions related to the core competencies and have responded to 32 requests so far this year, serving 23 organizations in 15 states, as well as the country of Tanzania. And then our ongoing dissemination efforts, particularly related to the new version of the core competencies, continue. So we've been doing a lot of work in that area over the last year or so to really make sure people have access to the new version. Since we last met and discussed this topic, we did do a session at the NACHO 360 conference again this summer as well around the core competencies. That session was a virtual session that was available on demand to conference attendees. And we are currently getting ready for the American Public Health Association meeting in November, where we'll be doing 3 sessions that will touch on the core competencies. 2 of them are on, I think, the first day of the conference, November 6th, and then the last one will be on November 8th, but we'll focus on new tools for using the core competencies, as well as thinking about your workforce development programs in general, and addressing health equity related to the core competencies. We are also, as you've heard us talk about over the last few months since the revised core competencies came out, we're still working to update resources and tools and things like that to reflect the changes that are in the new version of the core competencies. So we've talked previously about competency assessments as well as the Train Learning Network. And I just wanted to mention that we have recently finished updating a prioritization tool that we provide that helps health departments and other organizations identify or kind of prioritize what are the most important core competencies for different jobs within their organizations. So we've just finished that update. It's actually not on our website yet because I need to figure out the new FTP process. But once I've got that down, it will be online, and we'll send the note out again through the council update like we usually do. But in the meantime, while you're waiting for me to figure out the internet, feel free to let me know if you'd like a copy. I'm happy to send you the materials that go along with that tool. I think that is my last slide, and we have 1 minute before our next presentation if anyone has any questions. I promised Ron I would get us caught up since he's not as good at this as Bill, so
I know I'm an amateur at it. So any questions for Kathleen or comments related to either of the 2 things that she breezed through: the academic health department, learning community and partnerships, and the core competencies for public health professionals?
And I'm also happy to chat after the meeting or anything like that. Feel free to continue to dump questions in the chat box. And thank you, Jim. I'm also looking forward to the new tools.
Yeah. Okay.
Fantastic. Well, thank you all. We will turn it over.
Super. Thank you, Kathleen, so much for filling us in on all this exciting work. So now I'd like to invite Liz Wiest, who is the Director of Education at the Association of Schools and Programs of Public Health, to talk with us about the core competencies for interprofessional collaborative practice. And these are currently under revision. and she'll talk with us about these competencies and how council members and others can get engaged in the revision process. So Liz, let me turn it over to you.
Thank you, Ron. Could everyone hear me okay? Yeah, it's good to be back with Council on Linkages. It's been a long time. I used to come to your in-person meetings so long ago, and it's wonderful. You have 90 some people on this group. You have sustained and grown. And I didn't want to take time from the last, so I'm taking time from mine. I'm just so impressed the way you do dissemination, collaboration. At ASPPH, we work so hard on developing competency models, and we could learn a lot from you in the way you sustain and disseminate. So I'm wearing a different hat today. I'm an advisory group member and on the planning committee for the Interprofessional Education Collaborative. And we started a core competency revisioning process last year. And we're so grateful for this time to spend with you just a few moments today to go over where we are and how we could engage with you. Next, Kathleen. So my objective is prepare you all to give some feedback on these competencies. If we have time today, that'd be great. But right now we are engaging in internal efforts, and we're about to complete our first modified Delphi internal survey of where we are with updating our framework. So while I will gather notes today, you're going to have some real solid opportunities to weigh in when we invite universal comment. We just are still getting our act together right now. Next, Kathleen. IPEC members, we have 21. We started off with 6 founding members, of which ASPPH is 1. And next, Kathleen. AACN is on this group and is an IPEC member, and of course, ASPPH, so Sue Swider and Paul Halverson are reps here. And you could see a lot of other colleagues with whom we have engaged interprofessionally. It's a really dynamic group, and I could try to answer more questions at another time if you have it about IPEC. Next. So both the Council on Linkages and IPEC, we strive to bridge academia and practice. And IPEC's narrower focus is promoting interprofessional ed for collaborative practice. So you'll see some nice links between the work that we do. Next. I wanted to shout out to accredited, and let me just put something in the box real quick into the chat. I neglected to put a link in there to the core competencies of which I am talking. And I would ask for a show of hands on those who are familiar with them, but I can't see all of you, so it would be lost on the group. But moving on to the academic foundations for public health practice of accredited academic public health, looking to SEAF here. SEAF's original MPH foundational competency for interprofessional ed, and I know that Dr. King is here in the house. Feel free to jump in, I'll give you a few seconds, was perform effectively on interprofessional teams, which is the absolute distillation of all the IPEC core competencies. Next slide. Last year, CEPH updated their criteria, and the current MPH foundational competency is really interesting. Integrate perspectives from other sectors and or professions to promote and advance population health, which I love. Dr. King, would you like to say anything about this update?
Just only that I think interprofessional practice, the word interprofessional sometimes means only interprofessional within the health professions. And we wanted to integrate sectors because in public health, as we all know, sectors working together is often where the change happens. It doesn't only have to be within the health professions. So that was the genesis of the change.
Thank you, Dr. King, and it's great. I know our people are still trying to get their arms around this, but we look forward to seeing great exemplars in fulfilling this competency. Next. All right, the IPEC core competencies are 4 in total. You see them there on the wheel, starting in the southwest corner, values and ethics. Moving right, east, if we can use the compass here, roles and responsibilities. Moving north, communication, and moving west, teams and teamwork. And if you look at the arrow along the bottom, the learning continuum pre-licensure through the practice trajectory is what we're looking to build here. Next. So the IPEC core competencies first came out in 2010. And the wheel that you see in the middle with the 4 core competencies I just mentioned were there from the beginning in that graphic as well. In 2016, the competency set was updated to broaden the focus, next, to emphasize population health and integrate population health throughout the existing set. It was minor tweaks and then some semantics about how we view the model, but pretty much the same original competencies. I don't think grew in number. We're about the same, 39 in the 2010 set, and I think we have 39 today. Next. The key drivers for our pending 2023 revisions. By the way, we plan on completing this effort and releasing the final set after some modified Delphi rounds in the next several months. It should come out in 2023, are very similar to your all's motivation, your drivers. We want to engage, empower our community. IPE, shorthand for interprofessional ed. CP, shorthand for collaborative practice community. Of course, a cyclical review. Many of us are of the understanding that competency sets last about 3 to 5 years, and then they may not be outdated, but they need to be refreshed. And that we want to make sure we reflect current practice, current research, policy, and practice. Next. So who is involved in the group overseeing this process? There's a core competencies working group. It's IPE and collaborative practice leaders and experts from across the nation. There are 23 on the working group representing all 21 IPEC member associations. And then we added 2 students from health professions programs. So that's been really neat to work with this emerging generation of students in the group. Each of the 21 IPEC member associations use their own process for identifying their nominees and coming up with their candidates who were selected to join the working group. On the next slide, you can see the fuller model. So at the top, the executive board of IPEC, of which for ASPPH, Dr. Magana sits on the board, and for nursing, Dr. Troutman sits on the board. I believe the board is now 7 or so individuals. Day-to-day leadership is provided by an 8-member advisory group. That's what I sit on, and it's coordinated by an IPEC associate director. So AACN has Kathy McGuinn on the advisory group. And then at the bottom there, the foundation is the working group that I just talked about, the 21 IPEC member reps and the 2 student groups, and they are submitting recommendations and other inputs and guidance to the effort. On the next slide, I'll go over just real quick. The working group is divided into 4 work streams: gather feedback and experiences, the group that's going out and trying to get the word out and capturing feedback from partner groups, the research and lit review group, I'll touch upon that in a sec, competency revisioning, that's the one that's doing the meaty work of the updating, taking in all the feedback from surveys, et cetera. And then report writing and editing group, they just finished up drafting definitions, operational terms that we're using. On the next slide, I wanted to call out that in our repository, we have gathered all these different kinds of foundational reference documents, of which, of course, the Council Linkages core competencies are there, your new ones. And on the next slide, I just ran through real quick. You could just advance here. The domains, it was fun going back to your latest competency set, that these 3 domains, communication, community partnership skills, management and finance, and leadership and systems thinking, those competencies of yours I pulled out there talk really nicely with many of our interprofessional core comps. And on the next slide, for our effort, some concepts of interest or constructs that we've been hearing over and over that we are doing our due diligence to weave in are, no surprise, diversity, equity, inclusion, leadership, which of course in interprofessional work includes followership, One Health, well-being and resilience, the quadruple aim, and team science. Team science is really taking it up a notch, maybe more than some of the other areas in the emerging early drafts. And on the next slide, oh, I wanted to, I'll put this into the chat too, if you just give me a second here. We have, here we are. We have a website devoted to this information, including frequently asked questions. Whoops, of course, I just lost your chat. Here we go. All right, so that's a handy reference to get more info. So what are we seeing here? Right, there's the site, little background info you could pop around, and you could advance to the next one, please, Kathleen. So what's next? What can you do? So I encourage you to visit the frequently asked questions page. It's there. Get ready for some online feedback sessions on the draft revisions in early 2023, and we'll invite universally anyone interested to give feedback electronically in digital surveying. Share questions, concerns, experiences, perspectives. Right now, we have, I think 15 minus 11. I think my math is 4 minutes. But Kathleen, you override if I'm off base. I'll take some here. There's my email. There's my colleague's email, Shelley McCurney. She's IPEC's Associate Director, and I think I could put that into the chat as well, so it's handy for you. And I think I'll go to Q&A.
Great,
Is
thank
that
you
it?
so much, Liz.
Yeah. Oh, sure.
We have 2 questions thus far.
Great.
Dory, please unmute yourself.
Thank you. Thank you for excellent presentation, Liz. I hope I'm not, I'm just so excited. My first meeting, first encounter with the council, and my energy is like, whoa. I was fortunate enough this past summer to participate in IPEC's Leadership Development Program in Atlanta. Still chewing through that and sharing it with my colleagues. One of the things that occurred there was kind of a pretty consistent need to point out that the language is not quite congruent with the core competencies and the focus, and that it still very much talks about healthcare, patients, so when I would bring it up and ask a question or provide feedback, they said, yes, we also mean public health, but it's sort of like it was implicit, and explicitly the language is incongruent. And so I'm hoping that there'll be some changes in the revisions of the competencies, and wonder if that's come up at all. Thank you again for your hard work.
Thank you, Dory. And where are you from? I'm not seeing the list.
Oh, I'm sorry. I'm with the University of San Francisco, the MPH program. I'm the director of high practice there.
Oh, terrific. I'm so glad you participate in that leadership program.
So am I.
And oh, good. Look forward to see what you do with it, with your learning. What you said is spot on. And actually this morning I woke up at an ungodly hour because I'm going over the terms right now. We have, like I just mentioned, the operational terms, and my task is, I have a draft slate ready for modified Delphi, is to make congruent the terminology, because we're kind of all over the place, and we knew that. And yes, for healthcare on its own, it will stand in, I think, maybe a few places, but for it to be more health, for it to be more applicable across not just the 21 IPEC professions, but those who will join IPEC and those who we hope will benefit from this new model. Thank you so much for that input.
Great, and we'll take one more question / comment. Dana?
Hi, I'll try to be brief, but same as Dory, super excited to hear. I didn't anticipate an IPEC presentation during this talk, and this is my first meeting with you all. And so just in terms of background, I have my One of my graduate degrees is from USF as well, funny enough, but it's a master's degree in healthcare simulation. So my first full-on exposure to IPE and IPEC. And I've been teaching in this space. I'm currently teaching an interprofessional practice course right now, where I've integrated or foundationally based it on IPEC competencies. And so in me recently joining APHL as manager of academic partnerships, that was one of my asks in the interview is there room for interprofessional education in public health? Where can we bridge that? And so just hearing you share this with the group, I think it's just really exciting and very timely. And knowing that my question wasn't too far-fetched in my interview, thankfully I still got hired. But I'm curious, I know we need to transition on, but for anyone who has incorporated IPE already into their curricula, if you can share that with me, just so I have ideas of what you're doing, because I would love to identify or explore opportunities for integrating IPE, or at least collaborative practice, into the fellowship and internship programs that we currently have going or soon to evolve and expand upon, because I'd love to make this a component of that wherever we can.
Thank you so much, Dr. Baker. And if you email me, let's continue the conversation.
Absolutely. Thank you.
Yes. Thanks so much, Ron and Kathleen, and everyone.
Thank you so much, Liz. And as things evolve and you're looking to get the word out, you know you can count on us for that. And we also know that if other people have questions and we receive them afterwards and we should send them on to you, we know that you'll respond as well. Super. Thank you so much. Okay, we're ready to hear about another competency effort, very exciting one as well. And this is one that's being led by the Regional Public Health Training Centers. They've been working on racial justice competency model for public health professionals. And exciting news, this is set to be released later this week. So we're going to hear from several of our colleagues from Regional Public Health Centers, Mayela Arana from the Region 2 PHTC, Dana Fife from the Midwestern PHTC, and Danny Zimmel from the Region 5 PHTC. So I'm not sure who's starting off, but I'm going to turn it over to you guys. Thank you.
Thank you so much. Mayela and Donnie and I are so excited to present and share our update with the racial justice competency model for public health professionals, especially because we're so close to releasing them. Next slide. And we just want to put the funding statement out there that the project is supported by HRSA grants. Next slide.
Okay, I think it's my turn to start now. Thanks, Dina. Hi, everybody. My name is Donnie Zimmel. I'm with Region 5. And Dina, Mayela, and I represent 3 of the 10 regional public health training centers that are part of a larger public health training center network. Collectively, our 10 training centers serve as the country's most comprehensive resource for public health workforce development. Next slide. So collectively, we seek to strengthen the skills of the current and future public health workforce through learning tools, continuing education, and student development. But individually, our work is tailored to meet the unique needs of those within our own regions. Next slide, please. So we've all been living and working through an infectious disease pandemic. That's no surprise to any of us here, but we have also been living through a parallel pandemic that's rooted in structural racism. And we know that the COVID-19 pandemic has highlighted the health disparities experienced by communities of color. There's a great body of data out there that supports that, but it's also important to acknowledge that there's been a social justice upheaval that our country's been experiencing. And while this didn't begin in 2020, it really kind of came to the forefront just a couple of years ago. Coming to the forefront were the many injustices that have occurred and are continuing to occur. Excuse me. Against marginalized, excuse me, racial and ethnic groups. So we know that agencies across, excuse me, I'm sorry. Sorry about that. I think something got stuck in my throat. We know that agencies across the country have been declaring racism a public health issue. According to APHA, as of August of last year, there were 209 declarations that passed in 37 states across a variety of levels, from city and town councils to local health departments to school boards. Next slide, please. So with these points in mind, and with a lot of formal and informal training needs assessment data at the regional and national levels, the PHTC network formed a racial justice work group last year. We really wanted to see how we could work towards racial equity and justice in a meaningful and an intentional way. And our work group felt that it was imperative for us to kind of come up with a clear, single, specific competency-based model on this topic for public health practitioners to be able to use. So very, very soon, the racial justice competency model will become available for those of us working in the public health training centers, for folks that are in governmental public health and others. And we anticipate it being able to be used in a variety of ways, including training, hiring, performance management, and policy development. Next slide. So at this point, I'm going to turn it over to Mayela to give a little bit of background information about our process.
Thanks, Donnie. I won't spend too much time because I know we're running out of time here. But this is just the process that we took in developing the racial justice competency model for public health professionals. So we started with creating a competency library that was just kind of a long list of competency statements or statements from different frameworks that were relevant to how public health can address health equity and racial justice. The kind of draft version of the health equity domain of the core competencies was included in this list of over 650 statements at the very beginning. Then we convened an expert review panel of about 35 public health practitioners from state, local, tribal public health departments, federal agencies such as folks from the CDC, non-governmental organizations, and academics. And the goal of the expert review panel was just to provide feedback as we created draft models and kind of tweak the language that we wanted to use within the competency statements. The next step was to just create those draft models based on the prioritization of the statements from the competency library. We, I think, went through maybe 3 or 4 drafts with the expert review panel. And when we came to kind of a draft that we were happy with, we did some validation. And so the validation that we did in the spring included a survey that went out to our expert review panel members that focused on kind of, does the model reflect the necessary and practical knowledge and skills? Is it relevant? Is it useful? And we also conducted a couple of town hall meetings at the NMPHI annual conference and the FIT conference also in the spring of this year. So based on the results of both the survey from our expert review panel members and the feedback that we received from the town halls, we did kind of a last round of refining the competency model. And we are very excited to say that version 1 will be launched on our website as of October 1st. So look out for newsletter emails and social media posts about that. As is, as all the competency models do, we will be periodically reviewing and revising the racial justice competency model just to make sure that it remains relevant for public health practitioners. Next slide. And just very quickly, we really wanted to align with existing frameworks and competency sets. So at the time that we began working on the competency model, the essential public health services had been revised with the intention of placing equity in the center. So we used the 3 domains from the essential public health services as the domains for our competency model as well. And again, as I mentioned on the previous slide, we started by using some of the health equity competency statements from the core competencies. And we, in the validation phase, worked with our partners at NMPHI to begin crosswalking the draft version that we had of the racial justice competency model with the new 2021 core competencies. So kind of very intentionally along the way, trying to align with existing models. Next slide. Yeah, so this is just kind of what our homepage is looking like right now. You'll be able to download the PDF version of the competency model as of October 1st. Next slide. And as Kathleen mentioned, APHA is coming up. We will also be presenting on kind of the development and some of the preliminary feedback. We're hoping to get some feedback in the first month of this launch that we'll share with you all at APHA. And it's actually the same session that it's the health equity through use of competencies session. So Kathleen and I will be presenting back to back. Next slide. Yeah, I think that's it. Feel free to get in touch with us if you have any questions, or if you are interested in maybe being a pilot tester. We have some next steps planned. So please feel free to get in touch.
So thank you all. We do have some time for questions and comments. First thing I'd like to do is apologize for butchering several of your names. Sorry about that. Won't let that happen again. And secondly, we will provide the link out to, as in the meeting materials, as well as put something in the Council on Linkages update, because we think everybody should learn about this. Questions and comments?
And we will look forward to seeing you at APHA.
Yes.
It wasn't until I saw your slide the other day that I realized the session was at 8:30 in the morning. I was like, oh, right.
Any questions or comments?
There is one question in the chat box about how this can be used in educational setting, which I know you all have thought a lot about. So just throw that out there.
Yeah, that's a great question. I think we were thinking a lot about I know here at Columbia, we've been doing some like racial justice audits on syllabus and curriculum. So I imagine that there's some opportunity for alignment there. But I think that that's something that we have to think a little bit more about, because I think we developed this with the public health training centers and training development in mind. But I can definitely see it being applicable to curriculum development or some kind of audits.
Dana just suggested reviewing hidden curriculum bias in course materials. Yeah, and there's several comments in the chat box congratulating you on all the great work. So I actually got the privilege of being part of this expert review panel as we went through the process, and I can attest to the amount of work that everyone put into this competency set. I'm really excited about seeing it hit the real world.
Thanks, Kathleen.
Great. Any other comments or questions? Keep them coming in the chat box too.
And people are talking about revamping existing public health courses and curricula, integrating into nursing curriculum. Yeah, lots of good ideas.
Definitely.
And Dory just dropped a note about all the competencies.
Great. Well, we'll close out this part, but again, please keep questions and comments coming in the chat box. I know we have 3 individuals who will be happy to respond, and maybe all 3 of you will respond. Thank you so much for bringing this to the attention of the council.
Thanks so much for having us.
Our pleasure. So we have one more formal agenda item. It's been chock full of content today. So let me invite Michelle back. And Michelle's going to talk with us about CDC's E-Learning Institute Fellowship Program, which currently is accepting applications. So Michelle, let me turn it back to you.
Sure, and I think Kathleen's going to put in the chat, just really briefly, we are accepting applications for the E-Learning Institute. And if this is relevant to your networks or partners, so please spread the word. It is meant for those that are training public health practitioners in the field, so not necessarily academic settings or degree programs, but those who might be at health departments, workforce settings like nonprofits in public health or health systems. And so this fellowship is for those who design or develop develop e-learning material, or maybe develop in-person training, or trying to convert their training into something that is online and virtual. So it is a deeper level of training from experienced instructional designers who serve as mentors. And you can share this link. I think PHF probably has also shared it on your LinkedIn page, so you can reshare what they've been sharing. Applications are open through October 21st. And if you could go to the next slide quickly, on this website, there is more information about checking eligibility for the program. And let me see here, there's so some of the details really quickly is that it's a 6-month part-time online fellowship for those who are normally at those beginner intermediate levels. Fellows create their own e-learning products, and of course, in partnership with Public Health Foundation that helps facilitate this, they gain hands-on experience. And really one of the value added is that they have coaches and mentors who are instructional designers. So the e-learning products are available through CDC Train at the end of the fellowship, and there are about 20 spots available. So federal employees are not eligible for this. This is really for practitioners in the field. And if you do have those who are instructional designers that are experienced on your teams or with your partners, they can also look to the site to apply to be a mentor. So I will leave it at that, and take a look at the link if that is relevant to your partners. Thanks.
Thank you so much, Michelle. And we did put in the chat box the link for about the Institute where people can apply. I can just attest to the value of this program. The content that's come out of the program in terms of those who've graduated is really superb. And it's a great value to the public health community. We do have a question. Would this be appropriate for clinicians, such as an adjunct to the PHI partnerships that were discussed earlier?
And I saw Lloyd had a qualifier about 20 slots.
Yeah, I just see that, right?
If it applies to clinicians who train the workforce in their healthcare systems, it could be, especially if it's related to, you were talking about intersections with population health, clinical, and public health. So if they are related to workforce training, not necessarily academic training, those clinicians could be eligible if they happen to be instructors as well for practitioners. I don't know if that answers your question, because I know you know your audience best.
Right. And Michelle, is it limited to governmental public health?
No, it's we actually, well, we're not including federal, but we do include state and local, but it doesn't have to be governmental public health.
Great, thank you. Other questions or comments for Michelle? Is it appropriate for nonprofit employees?
Yes, it is.
Aha, there we go. You're going to get an application from APHL now.
I hope so. Wonderful partners at APHL.
That's good. Any other questions or comments? All right, super. Well, we are coming to a close. Let me ask before we do and talk about the next meeting, is there any new business or other business to discuss? Okay, looks like the answer is no to that. The next Council on Linkages meeting, we have one more for this year, and that is scheduled for Wednesday, November 30th, starting at 12 p.m. And if you have any questions about that, you feel free to contact Kathleen. I'll also mention that, Kathleen, if I'm not mistaken, we added meetings this year to the usual number. And I think it was very much needed because the level of discussion that we've had throughout and the types of information that's been shared, I think have been very valuable to all of us. But let me ask if there are any comments, questions, additional thoughts that any of you have. And Amy, thank you for your additional helping us go through the chat box, monitoring that, responding to it. We really appreciate it.
You're welcome.
All right, well, without any further ado, let's adjourn the meeting and thank you all for your participation. And we look forward to the next set of discussions, and please be in touch with us between meetings as well. Thank you all so much.
Thanks, everyone.
Thank you.